So for this session today, I will be trying to talk about two topics. Next, please. Just starting with a recap or highlight from session 1 and 2. For those who attended the session, we talked about the concept of health economics. We defined health economics as the comparative analysis of different alternative options in terms of both cost and consequences. Next, please. And we looked at the different types of economic evaluations in healthcare: cost minimization, cost benefit, cost effectiveness, and cost utility analysis. Next, please. We talked also about the differences between RCTs and data that comes from real world, and how can we use the economic evidence to complement the or to complete the limitations of RCTs. Next, please. In session 2, we talked about the potential applications of health economics in decision making, including health technology assessment, which is the overall assessment of new technology from the economic perspective, social, ethical, legal, and clinical aspects. Next, please. Another important application of the health economic evidence, which is the use of health economics in formulary management at hospital and national level. Next, please. So the objectives of this session will be, hopefully we can do objective number 2. I just added because I thought maybe this session should touch more on the real world experience of pharmacists. The first objective is to discuss the critical appraisal of economic studies, because I know that a lot of pharmacists have to do the evaluation of new drugs for example, for inclusion in their formulary, and critical appraisal is most of the times part of critical appraisal of economic studies, should be part of this process. And some pharmacists, when they look into the literature, they find clinical studies and they know how to deal with these studies, they know how to critique them, they know the good study when they see it. However, when it comes to economic studies, they don't really understand them, and they don't know if it is a low quality study or good quality study. And for economic studies, it's not always the case that the study is perfect compared to RCTs, because they're not controlled, they're not prepared for or developed to be assessed by regulatory bodies. So, and they're also based on assumptions. So a lot of economic studies have several limitations and biases. So in my opinion, it's a good piece of knowledge and skill that a pharmacist need to have. So we will discuss the key study design consideration for economic studies, including the methodology, scope, result, and the way the studies are reported. Also provide the reviewer to provide high quality feedback during the assessment of new drugs. If we have time, we will look at different ways to improve efficiency in pharmacy practice. Next, please. Next, please. So as we discussed before, economic evaluation is now is no more, there is no way around this to conduct economic evaluation for new technologies and in general, and for pharmaceuticals in particular. And if you want this to play a role, a powerful role in decision making, then it should be conducted in an appropriate way. Next, please. So this shows the 3 stages of a well-designed pharmacoeconomic evaluation. Just like any other study, it starts with the planning phase. by defining the research question, reviewing the literature, defining the perspective, determining the comparators, and also the appropriate methodology, selecting the time horizon. And then we have the stage where we have to perform the analysis by identifying, measuring, and valuing costs and outcomes, and then modeling these costs and outcomes, calculating the incremental cost and the incremental outcome, doing discounting and adjusting costs, performing sensitivity analysis, and then presenting the results. And I will talk in details about all these steps. Next, please. So just like any other research, the most important step and the first step is how to develop research question. The research question must be defined, and it must be defined from the beginning of the study because it will impact the methodology, the parameters collected, and all the other steps of the study. So if you are looking at an economic evaluation, you need to look into the question. Is the question clearly defined? Is it focused? And does it highlight the importance of the study to policymakers? Next, please. Then we have the literature review, which is a comprehensive description of the disease. You need to look at the disease history, the prevalence, the incidence, all the epidemiological data, the patient journey in general, what is the current guidelines, what is the current practice in your setting, and what are the unmet needs and the treatment gaps. All the interventions that are available in your setting should be also described clearly in the literature review, their mode of action, their indications, safety profile, efficacy, dosing, and all clinical aspects of the available interventions. You need also in the literature review, you should find the value of a new technology and how it can impact the practice or the decision making. You need to also to find a description of the target population. Next, please. And ideally, the ideal situation is starting with a systematic review of a primary clinical endpoints from RCTs. Most people, when they want to conduct a good quality economic study, they usually prefer to start with systematic review. Why? Because it's worth it. Because at every step of your research, you're not researching a real world cohort of patients. It's a hypothetical cohort, and you need to find the parameters to feed them in your model. So you are completely looking into the data. So it's worth it to start by doing a systematic review, searching in the literature, finding all the relevant studies, do the systematic review and meta-analysis if applicable, and then use these findings of systematic review to feed your model. You need also to look into other pharmacoeconomic analysis conducted, the cost of studies that have reported the cost burden of the disease, the quality of life, and also national and international treatment guidelines. Next, please. One of the important steps is deciding on perspective, and this is specific to economic evaluations. Next, please. So perspective is the viewpoint from which the analysis is conducted, and with changing the perspective, it impacts the findings, the methods that you use, and most of the times people take the, I would say, the healthcare system perspective or the government perspective, public perspective. But with changing the perspective, most of the methodology will be impacted. Next, please. Next. Also, another important factor is when you look at the study, you need to find that the authors clearly define the comparators. Because, for example, if the author is, let's say, industry sponsored, and they want to have the new intervention to look cost effective, they will choose a very expensive existing drug and then compare it to it, which will make their new intervention look cost effective and cheaper than the old one. However, if you are aware of the standard of care, when you look at the study, you will know that this is not the appropriate comparator, or maybe it is appropriate in another country or another setting, but not necessarily correct in your country. So you need to make sure that you look into the comparator. Most of the times they will call it standard of care for local practice, or the most effective clinical option, or minimum clinical practice, lowest cost alternative that is superior to placebo. Next, please. So the appropriate methodology, as you remember, we talked about the different types of economic analysis, and choosing the appropriate method will depend on the, as I said, the perspective, the objective of the study, the question that you're trying to answer. So you need to also consider what outcomes you want to have, what are the costs you are using. So all of this will impact the methods used. So the method in any study should be clearly stated. The authors should state what methods they are using. You should not be trying to figure out what methods they are using from the calculation or from the tables that they provide. It should be credible and transparent. Next, please. So this is, as I said, the different types. For example, if you have a study that looks into the cost impact of adapting a biosimilar, then you know that the biosimilar have the same clinical impact as the brand. Then you need to do cost minimization analysis, because this is the most appropriate study design. If you go and do cost utility analysis, then you are unnecessarily complicating your case, and you might have wrong findings. Next, please. Selecting also the time horizon. As you know, in clinical trials, they are conducted within a very specific time frame, sometimes 6 months, 1 year, 2, 3 years maximum. However, for economic models, they are most of the times done to capture the impact of the intervention on the long-term consequences and costs. So you have a hypothetical cohort of patients. You will assume that they enter the model under certain conditions and the probabilities that you get from the literature. And then you have to decide on a time horizon that should be suitable and appropriate for your study. So one of the things that you need to look at is the time horizon. You will find, for example, says that 1 year time horizon, lifetime horizon, or maybe 30 years time horizon. Next, please. So this shows the difference between lifetime horizon and short time horizon. Most of the studies are done based on lifetime horizon, where the time is extended sufficiently to capture all the future relevant clinical events that the patient may experience in their lifetime, and also to calculate the associated cost estimates. For example, if you have an intervention that treats a long-term disease, for example, diabetes, then you need to assume that you have 100 patients who will be diagnosed at their 40, and then they will enter the model for lifetime, or assuming 30 years. And then you put probabilities for all the events that they may experience with this cost associated with them. However, in other scenarios, it might not be necessary to complicate your model with 30 years or lifetime horizon. It might be enough to calculate the model or to run the model for 6 weeks, 6 months, or maybe a maximum a year. For example, if you are assessing the cost effectiveness of an antibiotic. Next, please. Sorry. So all of the things that we talked about are part of the planning for the study. So if you want to perform the analysis, the number one thing that you need to do is to identify, to measure, and to value costs. And costs here are either direct costs or indirect costs. Direct costs can be medical direct costs, such as the cost of medications, hospitalization, the cost of staff, supplies, equipment, laboratory, radiology, and the cost of diagnosis. There are also direct costs that are not medical, such as the cost of the travel of patients from a rural area, for example, the cost of home care, the cost of transportation. There are also indirect costs, including the costs attributable to productivity loss due to the patient's absenteeism from work, or even presenteeism, which is the lower productivity at work when the patient is actually attending or going to work, but not functioning as his when he's not sick. There is also the cost of loss of income or unemployment due to the disease. Next, please. So this must be the evaluation or the identification of cost. You need to make sure that they included all the relevant costs for each intervention. You need to make sure that they used local data. And if they are using data from another country, which is called transferability, it's done using a valid method. You need to make sure that there is no double counting. And by double counting, I mean that the cost for the same item is counted in 2 or 3 or more items. For example, if you are calculating the costs of visit, perhaps if your intervention require only 2 visits per year. However, you are also calculating the overall cost of side effect, and then you include the cost of visit again while the patient is coming anyway. So you need to make sure that they are not counting the same costs twice or more. Next, please. So these costs must be described comprehensively. Their selection must be justified. And also the references or the source of cost data must be mentioned clearly and not as a reference. For example, you need to see or to have a table that says that, for example, the cost of managing angina is, for example, 200,000 Saudi riyal, and my reference for cost data is MOH database, for example, or X study published on blah, blah, blah. You need to mention clearly where you got the data, and if you can provide access to the cost data that you are providing, you need to mention it clearly in the table. And this should not be an appendix. Also, resource usage should be also clearly reported and justified. By resource use, I mean, for example, if you said that the cost per day of hospitalization is, for example, $1,000, then you need to also mention how many days of hospitalization you expect. What are the units needed for each resource? Next, please. Same goes with outcomes. Everything should be mentioned clearly, and the selection of outcomes should be justified. Most of the times, most commonly, the outcome in most economic analysis is QALY, which is a unit that is capturing both the benefit in quality of life and length of life. There is also DALY, which is disability adjusted life year. There are several natural effectiveness units that we covered in the last two sessions. So these outcomes must be clearly stated and defined, must be appropriate for the type of study, must be also local, and it should be identified for each treatment alternative. You need to say that option A will give us, for example, QALY gain of 3 or 5 per lifetime, while intervention B give, for example, 10 QALYs per lifetime. Next, please. Next is modeling, and we covered modeling in session 1. So modeling is basically a mathematical simulation using the computer to simulate the patient's journey. It can be done on patient level or population level, and it's used to model the long-term consequences of using a technology. Next, please. So we are, as I said, we are using the clinical outcomes that we got from the trials or the local quality of life data that you collect from the patients in the clinic, local epidemiological data, and then we feed them in the model that we have. The most commonly used, as I said in last session, is decision trees and Markov models. Next, please. Next. So this is an example of decision tree, and we discussed this in last session. Next, please. A Markov model and the transition of states of patient from different disease states. Next, please. So regarding the appropriate or the best practice of modeling, you need to make sure that the model type is appropriate, relevant to the type of the study. It is justified clearly why I'm using this kind of model in my study. It should be also consistent with the perspective, the study scope, and the objectives. All the model structure must be described comprehensively, including the different health states, the cycle length, different pathways, the probability that I'm using in the model. And then if you are building the model in a software or in Excel, then the physical model should be supplemented as a supplementary document. All the key parameters, for example, epidemiological data, probabilities, utilities, QALY gain should be also presented in clearly in tables. Next, please. And then after modeling the outcomes and costs, then we calculate the ICER, or the incremental cost and outcomes analysis, incremental cost effectiveness ratio. We covered this previously. However, it's just the incremental cost divided by the incremental effectiveness, and these data are derived from the model. Next, please. Then also the cost effectiveness threshold should be clearly defined and justified. And usually most studies will not include cost effectiveness threshold. Why? Because a lot of countries doesn't have a cost effectiveness threshold that is agreed upon at national level. However, in general, cost effectiveness threshold is 1 to 3 times the GDP per capita in any country. So it should be clearly defined. For example, my ICER is, say, 20,000 US dollar, and against the cost effectiveness threshold that is commonly used in, for example, the US. This is called, could be cost effective. Next, please. Discounting and adjusting cost. Well, this is, I believe it's too advanced. However, I'll just give a quick idea about it. Discounting is usually used in studies to reflect the time preference of decision making. And just simple example, if I give you today 100 US dollar, maybe you prefer more to have them today compared to 500 US dollar in 5 years. So it's the present value of a good or a benefit compared to its value in the future. Next, please. After conducting the analysis, because it is based on hypothetical cohort, a lot of assumptions, data that are derived from different studies, some of them might be from other countries, it is always a good idea, and I believe it's a must, to do a sensitivity analysis. And it's done usually to test the robustness of the trial or the study. So what you do is you do appropriate type of sensitivity analysis. For example, if you want to test certain parameter, whether if you find, for example, that your drug is not cost effective, then you fix everything in the model and then change the price, lower the price by 30%, and run the model and check if the cost effectiveness was affected. If yes, then you will say that sensitivity analysis showed that cost effectiveness was significantly improved by reducing the price, or by, for example, changing the prevalence, or if I change, for example, the cost of one of the complications. So you keep on changing the parameters up and down, and test the robustness of your findings. Next, please. Presentation of results is always important in any type of a study, but in economic analysis, it's very important. Why? Because it's a model. You have a lot to say, and it's better to have a good visual presentation of your data. And then most of studies will report their presentation as cost effectiveness plane. Next, please. And cost effectiveness plane is something like this figure. It shows the probability of the drug being cost effective. For example, anything that fit in the upper right quadrant of the figure will be a good intervention that is more effective than the current. However, if they fall below the blue line, it means that it's cost effective, because this represents the threshold. So any good quality economic evaluation should have a cost effectiveness plane. Next, please. Another kind of visualization of the result is the cost effectiveness acceptability curve, or CAC. And it shows the probability of your intervention or the new intervention being cost effective at different willingness to pay or the different threshold values. So if you can see from this graph, the probability of the intervention being cost effective at 20,000 pound, which is the threshold in the UK, is 80%, which means that maybe the HTA agency in the UK will adapt this product, because there is high probability that it will be cost effective at their threshold. Next, please. So in summary of this part, any good pharmacoeconomic analysis should start with a clearly defined research question, clearly defined perspective. Are they going to take social perspective or healthcare system perspective? However, it is preferred that you have a societal perspective because it consider all the impacts of the intervention and everything in the society. The choice of comparators should be consistent with the setting, with the real life standard of care, with the study objective, with the indication that you're studying, and the choice of economic method you are conducting should be appropriate to all the above, to the objective question, the nature of the disease, the comparators that you are considering. Next, please. A time horizon should be long enough to capture all the relevant future cost and clinical consequences. All the relevant costs and outcomes must be identified, measured, detailed in the report, and they should be discounted at the same rate, which is the time discounting. Next, please. The model structure should be described extensively with details, with all the use of assumptions, parameters, inputs, the source of the data that you use, and further sensitivity analysis to address the uncertainty and to check on the robustness of the model must be also mentioned. The visual representation of the cost effectiveness plane and cost effectiveness acceptability curve should be also reported in the study. Next, please. So this is part 2. I'm not sure, Dr. Hijazi, do we have time for this?
Yes, we have time, Dr. Hana. You can continue, please.
I'll try to be brief. So I thought this is very important because it, as I said, it touches on the real life experience of pharmacists, the everyday operation, which is where are where can we find sources of inefficiency in the pharmacy practice, and how can we address these sources? Next, please. So as we discussed before, the cost of healthcare is rising in unsustainable rates. And this includes the spending on medications, if we look at pharmaceuticals, and also in managing medication-related problems. Pharmacists in particular are central figures who can help in reducing healthcare expenditure through cost saving and cost avoidance. Cost avoidance refers to when there is, for example, complications, when they expect these complications and they avoided cost saving in trying to minimize the waste. Next, please. So let's look at the sources of inefficiency in pharmacy practice. Next, please. One of the most important sources of inefficiency in the system, not only in pharmacy practice, is the delay in diagnosis and treatment access. When patients do not reach to the physician or to the healthcare system in timely manner, then they're progressing. And if we are talking only about the economic perspective, they will cost the system more. Also, delay in treatment access, whether it's delay for approval of the drug, delay in regulatory approval by regulatory agencies or by reimbursement bodies, or for inclusion in the formulary, it leads to inefficiency because we have a drug that was developed by the industry. They spent millions or sometimes more on developing these drugs. They're out there in the market and we are not using them. And this is a source of inefficiency. Next, please. Another source of inefficiency is the use of ineffective treatment options. And this is a common scenario lately. Regulatory agencies are approving drugs based on low quality evidence, for example, single arm studies, phase 2 studies. So the evidence behind these drugs is not adequate, or sometimes is adequate, but the benefit of these drugs is only 1 year of 1 month of progression-free survival. So there is no real benefit in terms of quality of life. We have patients who gained only 1 month of, for example, let's say, they don't have progression on radiological imaging, for example, but the quality of patient's life is deteriorating, and we're spending millions of riyals or dirhams or dollars on this medication. So approving interventions with marginal or limited benefit is a very important source of inefficiency that we need to look at. Next, please. Also, poor adherence to treatment, lack of compliance, and also medications error. Next, please. Lack of value assessment. We're not assessing the value of the new intervention. So new drugs are approved by, for example, EMA or USFDA, and we just add them to the formulary without assessing their value using economic evaluations. Next, please. Lack of real-world data. So we don't have data to assess the interventions that we adapt. We have new interventions, we add them, and we don't go back and collect data to see if these drugs were really effective in our population. Next, please. So this to just sum up all the sources of inefficiency: lack of value measurement or assessment, adapting drugs with limited or marginal benefit, medication errors, poor adherence, lack of data, and delay in diagnosis. Next, please. So how to address these issues? How can we improve efficiency in pharmacy practice in particular? Next, please. Well, if we look at assessment and uptake of new drugs, we can do risk-sharing agreements or early access schemes to improve the access to new interventions, the use of health, assess the value of these drugs, and also to do ranking of new technology or prioritization based on the value. We need also to look at full societal value. Perhaps you're adding a drug that is cheaper, but it doesn't improve the patient who is, for example, disabled. So the overall value, you're losing a functioning citizen or person in your society. Next, please. Empowering also the role of clinical pharmacists who can eliminate adverse drug reactions, who can conduct medication reviews, who can develop drug use policies, who can do counseling to reduce the errors and improve compliance. And also, clinical pharmacists can conduct evaluations for formulary management or participate in ward rounds. Next, please. So, as I said, pharmacists in general and clinical pharmacists in particular, with their unique position in the system, can have a very positive impact especially in high-risk environments, to prevent adverse drug events, in reducing morbidity and mortality, and also to limit the overall healthcare cost of these complications. Next, please. Next. So, in general, the role of pharmacists to participate in medications use review, ward rounds, also in pharmacists manage outpatient clinics, especially the one that the clinics designed for long-term conditions such as diabetes and hypertension. Retail pharmacists also can have a very important role in improving the efficiency by, for example, suggesting alternatives, cheaper alternatives, by, for example, avoiding the unnecessary use of the system. If they can prescribe OTCs that can help the patients, conducting antimicrobial stewardship programs, and I have example here to show, and also the appropriate use of generics and biosimilars in the hospitals. Next, please. Also, as I said, the role of the pharmacist in formulary management by conducting comprehensive assessment of the drugs, restricting the drugs to specific physicians, to specific patient groups, or even disease states, developing drug use policies, conducting economic evaluations, and also drug use evaluations or annual reviews. Next. So this is the study I was talking about the antimicrobial stewardship programs. So as you can see in this study, with the introduction of antimicrobial stewardship program in ICU in one of the tertiary hospitals in Saudi Arabia, not only it improved the clinical outcomes, reduced the mortality, reduced the resistance, but also it reduced overall costs. Next, please. So as you can see, this is the impact on cost. If you look to the graph on the right, the cost before the antimicrobial stewardship program was around 1.85 million Saudi riyal. The cost was reduced by almost 40% to around 950,000 Saudi riyal. Next, please. Other strategies to optimize the use of available workforce, strict administration policies, the use of evidence-based guidelines and protocols, limiting the unnecessary hospitalization, reducing the length of the stay, and better control of procedural supplies.